I'm Jason Hine. I'm going to talk to you about subarachnoid hemorrhage and a practical approach to this lurking monster. So why care about what I have to say? And all these PKs, you got to ask yourself that question. 2% of ED presentations as a whole are going to be for headache. About 2% of these are going to be subarachnoid hemorrhage. So big haystack, tiny little needle, which probably accounts for about 5 to 12% in the data initial miss rate for the ED presentation for subarachnoid. So if you don't want to be that guy missing these, listen up. That guy or gal, fem and nem in EM, remember the these two. All right, so the obligatory slide about me. I'm a practitioner in Southern Maine Healthcare, the educational coordinator there. I'm a clinical associate professor for Tufts. I'm the founder and keeper of EM Sandbox Podcast, and I have no relevant financial relationships. So the questions for the PK, these are the objectives. They are in your handout. Just ask more practically the way we should be thinking of these things. What makes for a high-risk patient for subarachnoid or a low-risk one? And then you got to say, Jason, where's the data for that? How, prove your point. And then finally, how do I work these patients up when I've ID'd a high-risk patient? So to use a case, you should be always using in case to frame these things in your mind. 52-year-old lady, history of hypertension, presents with a headache. Started about 5.5 hours ago when she was carrying some laundry. She's had migraines before, but this feels different, more intense, more diffuse. It worsened to its max in about 45 minutes, and now she feels like her right neck musculature is getting sore. So with that in mind, you got to say, what were the high-risk features in the history of physical exam for her? So we're going to use the Ottawa rule to frame this in our minds. For those of you who haven't seen the rule before, here it is. The very first thing you have to do with a rule like this is know your hard stops and your green lights. So green light for patients 16 years of age or older with a non-traumatic headache that peaks within an hour. Big red light if you have new neurodeficits, suppressed GCS, prior history of aneurysm, subarachnoid hemorrhage, or brain tumors, or obviously if this is like all the other headaches you've had before. And then note the language here if you're entered into it. Investigate further if any of the following. Age greater than or equal 40, neck pain or stiffness, witness LOC, onset during exertion, thunderclap headache, and limited neck flexion on exam. All right, so the data here now for that, they use this definition for the subarachnoid hemorrhage, which I thought was reasonable, and there's no gold standard to confirm it, so there's just really thorough follow-up, which has kind of become the default gold standard. 3 studies looked at it, 2 prospective by Perry, 1 retrospective by Bellolio. And what they wanted here, right, they wanted a rule-out rule. They wanted to be able to say if you were negative on Ottawa, you had no chance of having a subarachnoid hemorrhage, which is great. And they achieved that. I'd say 100% sensitivity, obviously varying confidence intervals by the number of patients, but 100% sensitivity in all 3 studies. What it cost them, though, was their specificity, 7 to 15%. And so if this was a unidirectional rule, if you listen to MRAP in March, if you could rule people out that way and then use gestalt going forward, that'd be great. But it says investigate further if any of the following. And Perry himself, in one of his studies, he saw decreased utilization. In his other one, though, it increased the number of imagings and things we're doing. And I think we could do a little bit better than imaging everyone age greater than 40, for example. So let's just look at the data a little bit more to find the high-risk patients. So Perry gives us these great tables that you can read very clearly here, right? But really what it has is patients with subarachnoid hemorrhage and patients without. And some of the differences are going to be statistically significant. Only some of these, though, are going to be clinically relevant. So crossing out the clinically irrelevant ones. Note I crossed out age. Both had a median age greater than 40, which goes against their rule. But taking again, pain severity of 9 versus a 10, time to peak of a 60 seconds versus 30 seconds, you can't use those things. So the elements that are high risk and clinically relevant, statistically significant and clinically relevant are right here. Thunderclap headache, worst headache of life, LOC, and in particular, neck pain on history, stiffness or exam, and vomiting. So it's taken away age and it's taken away exertional component. It's not that different than the rule, but no in particular this bottom aspect. This should really make you concerned. So coming back to our case, who's going to work this lady up? One guy? I would. So talking a bit about the workup, mostly we're going to be talking about timing, so I'm not blowing anyone's mind, I'm sure, saying that the non-contrast head CT is the backbone to assess for subarachnoid hemorrhage. But what we're asking now is with this newer generations, can it be a standalone test? And Perry has a good paper on this. He has a huge amount of data. So almost 1,000 patients got a new generation non-contrast head CT within 6 hours. And he found that it was a rule-out test, 100% sensitive with confidence intervals 97 to 100%. Dubois took his paper and put in a meta-analysis with 4 other ones, various sort of heterogeneous data, but they took a worst-case scenario and they found a 99% sensitivity. So from this, many people, myself included, would consider a 3rd generation or newer head CT with the indication of sudden onset headache or rule out subarachnoid hemorrhage, read by an appropriate radiologist to be a rule out test. But then you got to ask yourself, what if a CT ain't enough? What if you read this, you don't believe it, or more likely, you're past time? So sorry to everybody who's here hoping that I say you don't have to do LPs. That's still the standard. But where I can help you is this really pesky question of, is this a traumatic tap or a true subarachnoid hemorrhage? So say you go in with an off-service resident, you do an LP, and you come out looking like this. It's just a goddamn bloody mess in there. How are you going to know if what you just did was a traumatic tap or a subarachnoid hemorrhage? So Perry, back at it again, 1,700 LPs for his huge data set, 641 of which were abnormal, including 15 aneurysms. So you like to see a few more aneurysms there, but comparing the patients with true aneurysms versus the ones that were not, whoops, there we go. Looking at the RBC counts, they were able to draw a line in the sand at 2,000 times 10 to the 6. Now remember our pathophysiology though, right? RBCs lyse into xanthochromia. So having a high-risk patient be either of those, 2,000 times 10 to the 6 RBCs and or xanthochromia, they caught all subarachnoid hemorrhages, and they took out the vast majority of traumatic taps. And so finally, the last sort of question is, are there alternatives to CTLP? Really, we're talking about CT, CTA, and MRI, MRA. Can CT, CTA replace CTLP? In terms of sensitivity, the answer to that question is probably yes, as you see in this article from McCormick. But really, you have to ask yourself is, should it be? And to frame that in your mind, there's a great little study of ED patients with acute headache, all got CT, CTA, LP. 106 patients, 6 aneurysms found on CTA. Only 3 of those were subarachnoid hemorrhage by CTLP. So your incidental rate is going to go up, and you have to ask yourself, what patients are you harming by doing that? And then MRI, MRA, really limited right now by availability, but it's going to be particularly useful in patients that have a long time from ictus if you have it available to you. So to revisit our case real quick before closing, our patient, it was a busy day, excuse me, a busy day. Your CT head was negative, but she had an LP done. She was positive by both cut points, and she had a 7mm aneurysm that was treated without issue. And in conclusion, so the audible rule is a good rule-out rule. It may increase your utilization rate. You may be doing more to patients or working more patients up. The high-risk elements in particular are here, paying really close attention to neck pain by history, stiffness on exam, and vomiting. The CT done at less than 6 hours, in my opinion, is a rule-out test with tight confidence intervals and data to support it. And your positive LP is going to be 2,000 times 10 to the 6 RBCs and or xanthochromia. That's it. There's some references and questions. Sir.